dentist.
Okay, are we ready?
We're ready.
All right, so I'm going to give you a little kind of broader overview of what the project involved, and then kind of focus on some of what went into the development of the guidelines and what specifically the guidelines entail and what kind of medications you should see and won't see that you might have seen in the past, also, and sort of what the reasoning for that is. Let's see here. This is disclosures. So some of the challenges in terms of pain that we looked at as a group of providers early on was that there was just a wide variation in our practice, both from provider to provider and from hospital to hospital, and there weren't a lot of guidelines that were established, and so we wanted to move forward with that. One of the biggest challenges we all have, both with providers and nurses and families and the staff, is to try to distinguish between pain versus agitation and discomfort. So it's important to think about those two things differently, because really the approach you have should be tailored to the specific symptom that the patient is having. And the biggest sort of distinction would be if your a patient's undergoing a procedure like a lumbar puncture or a venipuncture or a chest tube, then that is really more pure pain that they're experiencing in that situation. Whereas if they're intubated chronically, or if they're having some other thing that's irritating them, it's more discomfort and not pure pain. Now, there's certainly a lot of overlap. I mean, if you're doing an LP and a baby is crunched up and uncomfortable, then they're obviously going to have agitation from the positioning, and then they're also going to have the true pain from having a needle stuck in their back. So that's not to say those two don't overlap, but it's important to think about them a little differently and think about what is really driving the symptoms that your patient's having in terms of trying to choose the best pharmacologic and non-pharmacologic measure to make the patient more comfortable. In one of the challenges in terms of developing guidelines is that there's just a wide array of patients, conditions, and a wide array of experience that you're trying to treat. So we try to sort of break them down into some of what are some of the factors. Certainly minor procedures like a venipuncture or a heel stick is something that takes a few seconds, whereas patients undergoing chest tube placement might be more ongoing. Not just the placement of the tube itself, but the tube being in there for hours or days is going to be uncomfortable and painful. So there's acute versus chronic conditions, and then there's also just the practical nature of some things are more emergent, and you can't wait forever to get everything together to put a chest tube in, and others are a little bit more planned, like a lumbar puncture, for instance, is never really an emergent procedure. So the things that we worry about in terms of the medications are that there are some side effects to anything we give, specifically for some of the narcotic medications and pain medications. We see hypotension, we see apnea, and then there's also some evidence that there's neurodevelopmental impairments. It kind of hurts the babies long term. It's not just something that affects their immediate physiologic nature, but it has impacts on the brain and their behavior, and they can develop tolerance and withdrawal symptoms that you sort of pay the price for later on. So there's downsides to over-sedating, treating pain as well. So we wanted to be sure in developing guidelines that we sort of struck that balance and paid attention to the downside to some of the recommendations we're making as well. As Ferry mentioned, there were a couple FDA warnings a couple years ago that drove this. So the first one, about 2 years ago, basically said that there were some medications that used for general anesthesia and sedation that really were dangerous to children younger than 3 or pregnant women, and it may, because it may affect the child development of the development of the children's brain. They also said, though, that you can't just simply ignore pain in children because of this, because untreated pain itself can be harmful. And so there was really, I think providers felt like there was really no good answer to this. The FDA was saying, well, you can't use these medications to treat pain, but you have to treat pain, and they weren't really telling you what you should treat pain with. And so there was a little bit of a clarification a few months later where the language was a little bit lighter, but the net effect was that that warning was out there, and this was sort of an impetus for us to really develop some guidelines and have some frank discussions within our practice to figure out what our approach is going to be going forward. So we formed a pain team, and it really was truly multidisciplinary. We involved physicians, both neonatology and anesthesia, pharmacists who really had some key expertise in physiology and pharmacokinetics in babies, and then nursing, OT, PT, child life, nursing education, and so forth. And we really wanted everyone to kind of bring their expertise and perspective to the table to look at both non-pharmacologic and pharmacologic and all aspects of what this set of guidelines would entail. We did a literature review, formulated some guidelines, and then subsequently went out to educate staff. And now we're certainly at a phase where things have been worked out. A lot of things have been worked out sort of where this started at Cook, and now we're branching it out to educate and implement the same kind of policies and procedures that are each tailored to specific hospital locations according to their needs, both from a patient population standpoint and what their local facilities can provide. Just to mention some of the key things that we saw in the literature. So based on these FDA warnings, there was some really strong language that basically said there were some things that we're using in babies that really are kind of do not use. And probably the biggest ones for us in the NICU were midazolam and lorazepam, so Versed and Ativan. And these were things that we were commonly using in babies, certainly for procedures and definitely in the chronic kids. And there is some real good data, both animal data and human data, that says that babies who are chronically exposed to these medications have impairment in terms of the way their brain develops, and it causes long-term harm. And so we really wanted to focus as a group in terms of finding some good alternatives and really sort of using these medications as a last resort. And if we did use them very sparingly and transiently and not chronically, especially in the baby who's chronically intubated, for instance. The other thing we learned in terms of our literature research is that we were using morphine the wrong way. We were using morphine based on how adults and older children metabolize morphine, and really sort of ignoring some of the recent data on what babies do when they get morphine. And after kind of looking into this a little bit more, it made a little bit more sense in terms of some of the dosing things we were doing. And I'll talk a little bit more about that in the next slide. And the last kind of key highlight from the literature is that we found that there really was some new and emerging evidence on dextamethasone, which is Precedex, and it's easier to say, and I'll say that going forward instead. But really, we thought that this kind of offered a great new option for sedation, and it also would be a good replacement for the benzodiazepines that we're using. And the key thing here is, again, distinguishing between pain and sedation. So benzodiazepines, Versed and Ativan in particular, are great anxiolytics. So they treat anxiety, they treat agitation, they do nothing for pain. And so it's important to understand that going in and looking for something that would replace it. The Precedex is a good option because Precedex actually has function that treats both pain and agitation, and it has some sedative effects. And so it works synergistically with morphine to treat pain, and it also works independently to treat anxiety. And so we thought this would be a good target. And from our experience in the PICU, or experience at Cook, the PICU folks and the cardiac docs really loved it and had great experience with it, and it was really something that the anesthesiologists who were working with us recommended that we use more of, and so we went in that route, along that route. So a little more detail about the morphine. When we looked at some of the recent publications on how newborns metabolize morphine, it turns out that their livers, because they're very immature in the first few days of age, they metabolize morphine in a different way. And so without getting too much into the biochemical details, the little diagram up here basically shows you that there's a process called glucuronidation that occurs in the liver, and it can create these two different metabolites of morphine, and the one on the top called morphine 3 glucuronidide is something that neonates produce predominantly, whereas once the liver matures more, beyond a week of age and older, they produce this morphine 6 glucuronidide, and that's more along the way that older children and adult metabolize morphine. The key is that the one on the top actually works as an opioid antagonist, and so that actually causes pain or prevents the opioid from working, similar to Narcan, whereas the one on the bottom is the opioid agonist. So when you give babies large doses of morphine that their liver can't handle, they basically make this extra opioid agonist, and it's counterproductive. And so that kind of explains why, if you think about the last time you saw a real sick kid with meconium aspiration or sepsis or pulmonary hypertension, and you give them morphine, and the first few doses you give them, they feel great, and they're just out of it and comfortable, but then they really quickly develop a tolerance to it, and you have to give them more and more and more and more. And the reason for that is you're giving them too much, and giving them more is actually counterproductive, because giving them more causes them to produce this antagonist, and it actually inhibits the opioid that you've given them to begin with. And so essentially it doesn't really work on them well anymore, and you give them escalated doses, and they end up on other things like Versed and all that to try to get them under control. So the folks that did the detailed pharmacology analysis really recommended the doses that we've shown here, which so in babies less than 7 days of age, you really want to start bolusing at 0.05 milligrams per kilo or 50 mics, and that's about half of what we typically have done in the past. 0.1 was kind of a standard dose. And then the continuous infusion you use in those babies is really small as well, 0.05 to 0.01 milligrams, so 5 to 10 mics. And again, that's about 10 times less than what we were doing in the past. I mean, it wasn't unusual to start a baby out at 0.05 or 0.1 milligrams per kilo per hour. But when you do that, it builds up very quickly in their system, and they develop this tolerance. And so we've learned that in the first few days of age especially, it's very important to start at lower doses, because it actually works a lot better, and they don't develop tolerance, and you don't have to use as many ancillary agents and kind of chase them down and give them boluses. Once babies get a little bit older, beyond that week, then it's okay to increase the dose a little bit, but still not super high. You don't want to run into the problem of giving them doses that are counterproductive. So initial boluses of 0.1 per kilo are okay, but then still kind of keep your drip down in the 10 to 20 mics per kilo per hour range to avoid that buildup as well. And it also limits the side effects in terms of hypotension and apnea if you use those lower doses. So that was one of the key findings that we did in terms of our literature research, and one of the basis for the guidelines that we made. As I mentioned, the Precedex, this kind of gives you some information about kind of how it works in the brain. It has a physiologic response, decreases your physiologic response to both pain and stress, potent sedative and analgesic. The nice thing about Precedex is it doesn't have the respiratory depression that we see with opioids and with the benzodiazepines, so your babies are not going to get apneic because of the Precedex you're giving them. Helpful. And then there are also some animal studies that show that it can be neuroprotective, complete opposite to the benzodiazepines, which can actually be detrimental to the brain development. This is just a slide summarizing all the literature that's been out there in recent years in terms of Precedex. So there is some data out there that shows that it's effective and safe in babies, and that kind of convinced us that it was okay to start using it on a little more widespread basis. So here's our guidelines. In terms of trying to decide what guidelines to use, I mentioned that there were just a very diverse set of patients that we had to think about. So we kind of divided the guidelines into what are we going to use for sedation, number one. Secondly, if where there's painful procedures, what do we want to use? And clearly you want to sort of tailor the amount and the type of medication or non-pharmacological intervention to the type of procedure. So we sort of divided things into mild or minor procedures or moderate to major procedures. And then there's some weaning and tapering guidelines for the more chronic babies. and then intubation algorithm that Farron mentioned, and I'll go over with you in some more detail. Unfortunately can't see this in too much detail, but I don't really know if I can blow it up, but you'll get copies of all this. So this is the sedation guideline, and essentially the sort of the strategy is to use both morphine and Precedex, both in terms of boluses and drips, and you'll get a lot more detail about that from pharmacy as it gets implemented. And there will be order sets created as well that detail this as well. These are the guidelines for both minor procedures and moderate to major procedures, and it includes, some examples of what these procedures are. So, for example, some of the minor procedures are things like venipuncture heel sticks, tracheal suctioning, immunizations, and so forth. Some of the more moderate procedures would be things like chest tube placements and so forth. And so the idea for this is sort of the same way you're doing multimodal intervention with your non-pharmacologic. You want to do multifactorial, multimodal intervention with your pain control as well. So rather than just a big dose of morphine, you want to use a small dose of morphine and also some Tylenol and potentially other medications like Toradol, and then combine that with some of your non-pharmacological intervention, sucrose and the Buzzy Bee and things like that, so that you're sort of attacking the pain and the agitation kind of from all angles, and you're not exposing the babies to any one of the side effects from using large doses of morphine, for example. This is just some information about sort of that we've collected at Cook that kind of lets us know that it's working. So we had some goals in terms of eliminating our use of benzodiazepines and then reducing the morphine doses that we were giving, and we thought that doing so would eliminate the number of babies that ended up on methadone as a result of not mom taking methadone, but as a result of us giving them too much morphine. And so we looked at that over time. This is our benzodiazepine use, and so earlier, this is for 2017, so right around the time that the team was formed, our rate of benzodiazepine use was kind of in the 8 to 10 range, and over the course of the year, doing various things, we got it down, basically in the 2 to 3% range. So we feel like overall we had a pretty significant reduction in the use of benzodiazepines over that time through development of these guidelines and staff and provider education. This shows our median dose of narcotic that we were using, and it's listed in terms of milligrams per kilo per day. So you can see January, February, March of that year, the babies that were getting morphine or fentanyl were getting around 3 to 3.5 milligrams per kilo per day. And simply by changing our dosing and using ancillary agents, in the later part of the year, we were down to 0.4 or 0.6 mg per kilo per day. So basically a 80 to 90% reduction in the total dose of morphine or fentanyl that these babies were getting in less than a year. I think a pretty dramatic change in practice. And then this shows the result of that decreased exposure to narcotics. So earlier in the year, there were roughly 7 to as high as 10 or so % of the babies in NICU at Cook that ended up on methadone. And it took a while to get that change to occur, but by the end of the year, we got that down to the 2 to 3% range as well. So dramatic reduction in the amount of morphine we're using. Eventually, that led to a subsequent reduction in the amount of babies that ended up on methadone. We presume that also certainly decreased length of stay and improved long-term outcome. Those are things that are harder to measure, and we're not following it for sure. But clearly, all the process measures and immediate feedback that we got tells us that that what we're doing is working. Let's get through this. This is some more specific medication. So, last thing I'll talk to you about is the intubation medication. So, just like the pain thought process, there's lots of different situations when babies get intubated. And lots of different factors involved. So the biggest one is, do they have IV access or not, because that dramatically impacts what you can give them during intubation. And then the second biggest factor is sort of what's the level of emergency, and it's never a black and white issue where it's completely emergent or completely elective. There's lots of different scenarios in between, and so we wanted to try to tease that out as much as possible and make some different recommendations based on what the particular scenario was. And one thing in particular where a lot of our babies ended up getting intubated was this sort of when you just do in and out surf. It seems like that's probably the most frequent time that babies are getting intubated in our NICUs these days, is just to kind of give them in and out surf and have them on CPAP. So we sort of have a special set of guidelines for that, in part because when you do in and out surf, your goal is to get that baby extubated, and so you don't want to give them medications like fentanyl and morphine that are going to keep them sedated for a long period of time and not breathing. So here's a list of here's the guidelines, and you can see on the top that basically it's broken down into if the patient's has IV access or not. So if on the right-hand column, that basically it says if the patient doesn't have IV access, your options are, I'm sorry, it's a little out of focus and you can't see it, but your options are basically to use some intranasal, you can use IM atropine, intranasal fentanyl are the kind of the two options you have for those patients. When the patient does have IV access, we kind of break it down into emergent, and more elective, and then here's a special column that is for the in-out surf. So for the emergent patient, and the emergent patient, just to kind of give you an idea of what that is, it's not the baby who is being intubated in the delivery room at 2 minutes of age because they can't breathe. It's not the baby who is, you're doing chest compressions on and they have a heart rate of 10. This is the baby who, might get extubated and is failing, and you kind of need to intubate, but you can bag the baby and kind of get them stable, and you have some time to get the medications up. So in that situation, you have the options for fentanyl, fentanyl, and if you can't give atropine, it's fine. The atropine is also a kind of a recommendation if it's more semi-emergent or elective and you have time to get that. There's also some, leeway in the recommendations because you realize that the availability of these drugs is going to vary on hospital, and so it's sort of up to each individual hospital working with the medical director, with pharmacy and nursing, kind of figure out how to make these medications available, how to get them from the pitches, what the time frame is going to be in terms of helping you decide what you'll use. So those are all kind of discussions that need to be had on the local level within each individual NICU to kind of figure that out. I'll just go through in detail the in and out surf though, because this is a little bit different. So for the in and out surf, we basically wanted to kind of use the same routine of atropine and then fentanyl, wait, intubate, and then the idea behind this is that you then give Narcan after you're intubated, and that basically kind of blocks the effect of the fentanyl. The baby should kind of instantly become more active and spontaneously breathing again, and you can then extubate them to CPAP, and we've been using it pretty successfully in our downtown hospitals for quite some time, and it seems to go very well. So but I guess the last thing I'll mention that I forgot to is there's a pathway in here to use a paralytic, rocuronium, in the kind of non-emergent intubation. And there's a little caveat here that says that we really think that this is something we should only be doing in the presence of a neo or anesthesiologist, because once you paralyze a baby, it's reversing it is not easy, and it wears off in many minutes or sometimes hours, not just a few minutes. And so if you paralyze a baby and can't get an airway, hopefully you'll be able to bag them, but you might be stuck bagging them for an hour until they start breathing again if you paralyze them. So we really want to be sure that there's kind of the most qualified, or at least two qualified people around. I don't want to say that the practitioner's not qualified, but because many of them are more qualified than we are in terms of intubating, but it's definitely better to have at least a couple people around. It's not something you want to be doing by yourself at 2 in the morning. So that's kind of the caveat there. And again, each kind of peripheral hospital, that's discussions that the medical director can have with the nursing director in terms of if they want to institute this policy of paralysis and under what circumstances they want that to happen. But we do think that it's important to use it when you can. And again, our experience in the downtown hospitals is it really kind of makes things go very well and very smooth, especially in bigger babies. It's not necessarily helpful to paralyze a 700-gram baby, but the 3-kilo baby who's kicking and screaming, even if you've given them a lot of fentanyl, they're often still fighting you, and kind of giving them that muscle relaxant really kind of helps the intubation go smoothly. So I'd recommend to try to do that if it's feasible for your specific institution. That's all. Let's get through this. Those are some of the folks at Cook that were instrumental in working on this, in addition to Farah, who's representing Harris downtown. And at this point, we can, I guess, stop the recording, and we'll have questions. And you're welcome to email me or call me.